move ahead to our next panel of discussion, which is about precision oncology and targeted therapies for solid tumors, translating genomic insight into real-world oncology outcomes. This sits right at the intersection of science, innovation, and real-world impact. Today, precision oncology is no longer just about understanding the genome. It is about acting on it. And that's exactly what this discussion will explore. That how targeted therapies and genomic intelligence are being translated into a tangible clinical outcomes. And to lead this discussion, may I invite our moderator, Dr. Kripa Bajaj, Senior Consultant, Medical Oncologist at Omega Hospital, Hyderabad. Let's welcome our moderator with a round of applause. Thank you, ma'am. Thank you for joining. And joining her, this power-packed panel, we have an exceptional lineup of experts. May I invite our speakers, Dr. Suman S. Karanth, Additional Director, Medical Oncologist at Fortis Healthcare, Gurugram. Let's keep our hands rolling. Dr. Vanita Noronha, Professor and Medical Oncologist at Tata Memorial Center. Dr. Jyoti Bajpai, Lead Consultant and Medical Precision Oncologist at Apollo Cancer Center, Navi, Mumbai, and Founder and President of Immuno-Oncology Society of India, and former Professor of Tata Memorial Center, Mumbai. Dr. Anita Ramesh, Professor and Head Medical Oncologist at Savita Medical College Hospital, Senior Consultant, Medical and Pediatric Oncologist at Apollo Specialty Hospital, Kaveri Cancer Center and Multi-Speciality Hospital and ESI Hospital, Chennai. Dr. Chetna Bakshi, Consultant Medical Oncologist at Jupiter Hospital, Mumbai. Let's welcome our speakers with a round of applause. Now I hand over this discussion to our moderator. Ma'am, over to you.
So first of all, I would like to thank Voice of Healthcare platform for this wonderful opportunity to moderate the Power Pack women here. Two of them are my teachers, whom I always look up to for being so, inspiring. And thanks, ma'am, for being here. And other women are we all know they are very eminent people in the field of oncology. So today, it's been a decade I'm into oncology. I have seen genomics, just starting with PCR testing to snapshot mutation and later evolving platforms of NGS. Initially, it used to be the outside, we used to procure, services from outside. We used to send to abroad as well. But later, with all the healthcare leaders, amazing leadership in diagnostics, we got a multiple platforms now where genomics is done. It's really accessible to most of the people very affordable way. And not just testing, but also the access to treatment is very easy. Multiple Indian companies are coming up with very affordable options. Even the immunotherapy is right now very affordable. We saw immunotherapy, low-dose immunotherapy at Tata Memorial Hospital, how it translated into great clinical outcomes under the leadership of Kumar Prabhash and Dr. Vanita Noronha. And we saw now the availability of generic version at a very affordable cost. So now there is an interactive discussion about what are the clinical bottlenecks in the real world, what we are facing. And here we have a panelist who are from premier institutes like Dr. Vanita Noronha and the one who did in both premier institute like Tata Hospital and also working with Apollo, Dr. Jyoti Bajpai, and Suman Karanth at Tertiary Cancer Care Center. And Dr. Anita Ramesh, she is working with medical college, private practice and everything. And Dr. Chetna Bakshi, she is actually currently serving in Jupiter Hospital where the middle class income crowd, I discussed with her what kind of crowd you do address. She said it's a proper middle class crowd. So we can have a varied insights about what are the clinical challenges we are facing. So precision oncology has moved rapidly from discovery to clinical availability. But the real conversation today is about consistent translation into treatment decisions, which is most important for patients. Across this panel, we have perspectives spanning clinical practice, research, evolving therapies from high-volume centers to cross-domain expertise. The focus today is not just on innovation, but on how genomic insights actually influence decisions at the bedside. We'll explore now how to move from isolated success stories to more predictable system-level patient outcomes. We are going to discuss about how translating genomic insights to clinical reality, as well as how to build systems followed by rapid fire. Dr. Suman, gynecological cancers as well as solid tumors are seeing a rapid expansion of targeted and immunotherapy options with a lot of data. Initially, it's only just trastuzumab. Now there is evolving data with the immunotherapy, with all the targeted new evolving data is also there. And the benefit is not reaching patients uniformly. From your experience managing diverse solid tumors across a high-volume tertiary setting, so where does the translation of genomic insights into treatment decisions most commonly break down, and what would meaningfully fix it?
Good morning, everybody, and thank you for having me here, and thank you for that wonderful question. So I think this is a good time for gynecological malignancies because there's been an expansion of new biomarkers and hence targeted therapies, and the outcomes are getting better. But for all solid cancers in general, I think the question is, and the key challenge is the timing of doing an NGS panel. So far, the thought process is, let's do it at the end when a patient has already failed a couple of lines of therapies. It is not a salvage option. It should be brought up frontline. And we are seeing that with certain biomarkers. We started with lung, and then moving on to different malignancies, and now gynecological cancers. You need to identify and prepare or construct a treatment protocol for your patient depending on what kind of cancer they have and what kind of biomarkers they have it. So the timing is probably the most important thing. Secondly, the NGS panels are used left, right, and center, all sorts of platforms. Nobody really knows. I mean, I feel the person who is writing it should have some understanding of what they're doing and what kind of platforms they're using. Is that platform actually going to answer your question? Are you generating only information, or are you actually generating information that you can translate to the outcomes and actually have something to offer to the patient, and not just jargon of 10 mutations and say, oh, I don't have anything left. I think that is a very big challenge. And thirdly, understanding the report. I mean, obviously, we have such a wonderful panel, and the madams are stalwarts who actually led oncology here. But a lot of us, in the field still don't. It's an evolving practice, and we don't have a uniform understanding of interpretations of these molecules. So we should have a hub and spoke kind of model where we have tumor boards and educate the, help the medical oncologists and help the oncologists to actually tailor the treatment. And I think lastly, the access, because you may find a biomarker, but like the last panel, they discussed entrectinib, it's 5 lakhs a month. You have a mutation, you have everything, you have the drug as well, but the access, the cost, I think that is a huge challenge.
So doing the test at right time, at the same time, like interpreting the report is very important.
Yes.
Most of us do face a lot of challenges, like where interpreting the report. Dr. Chaitanya rightly said before that if someone comes with NGS report, we do ask them to come next day because a lot of things to be discussed in that.
Yes.
So most of us do that because we are still in the understanding. Maybe Vanita ma'am will be very confident enough, but still we are still understanding how to interpret report. And rightly, not all targets can be offered because accessible to treatment is the most important bottleneck what we are facing. Vanita ma'am, you are a pioneer in clinical research in oncology in India. So the research has been central to advancing precision oncology. So at the same time, there are often differences between trial population and real-world patients, especially in diverse settings like India. From your perspective, how do you view this in the context of solid tumors, and how can research approaches continue to evolve to better reflect real-world patient needs?
Thanks. So I just wanted to say thank you to Voice of Healthcare for this opportunity. Thanks, Kripa, for the question. So I agree with you. We are at a really exciting point, I think, in medical history and oncology history, because things are evolving so rapidly. We have so many new treatment options. So much of good precision-based research is happening. But does that translate to our patients? So in general, not just precision research, but any kind of research, the patients who are enrolled in the trial, who actually generate the evidence, those may or may not reflect the patients we see in the clinic, right? Those are fit patients. By and large, their performance status 0 or 1. They don't have comorbidities. They are younger. And over again, we have seen that this is a very restrictive eligibility criteria. As compared to that, in general, the patients whom we see in our clinic, they are older, they are not as fit. I mean, how many of our patients are PS0 or 1? By and large, they come with PS2. They have multiple comorbidities, they are on multiple medications. They have, most importantly, they have financial constraints. So our patients, in general, the usual patients whom we are seeing in our clinic are not actually reflecting the patients who were part of the evidence that we are actually going to apply to the patients we see in clinic. So how do we do that? How do we translate that evidence? So I think most important for us in a low middle income country, in an institution like Tata, or in multiple other institutions in India, I think our responsibility, our ethical responsibility is to ensure that we are generating appropriate pragmatic evidence. So we translate the evidence from global trials, but also try and generate our own evidence to answer the questions that our patients have. So we are trying to do that in a small way at Tata Hospital. So we are trying to design pragmatic trials, lower dose immunotherapy, lower dose targeted agents, increased intervals between administration of immunotherapy or these long-acting drugs. Maybe you don't need to give it every 2 weeks or every 3 weeks, using oral metronomic chemotherapy. So we need to generate pragmatic evidence. In addition, how do we translate the evidence that is there in clinical trials? We need, as you rightly pointed out, we need to have clinical decision supports. So perhaps multidisciplinary discussions, molecular tumor boards, where you have access to scientists, to clinicians who can put this evidence together. This I think should not be restricted only to elite institutions. This needs to be translatable across a lot of institutions. So perhaps we can have AI that helps us. We can have virtual molecular tumor boards. So I think there are multiple ways that we can translate this evidence, and I think this is the need of the hour for us.
Thank you, ma'am, for answering such a question. You're not doing it in a small way. You're too humble to say that. You're doing it in a very big way. For people who are students out there, like who are not like non-oncology students, I must say Dr. Vanita as well as Dr. Kumar Prabhash, they curated each and every trial which contributed a lot to the field of oncology in India. The reason why I included this question is real world and Tata-based trial, lot of correlation is there. The thing she mentioned, oral metronomic chemotherapy as well as low-dose immunotherapy. So Northern India, a lot of head and neck cancers are there. So accessibility to treatment is very, very, very difficult. But there are very great outcomes got noted with the trial from Tata Memorial Hospital. Congratulations and thank you so much for contributing such a great evidence, I must say.
And actually, I would like to add that there was a time when only 20% of the patient used to take treatment, but because of this trial, I think 80 to 90% of our treatment, we can give them the treatment because it is a low dose and they can afford it.
So the low-dose head and neck cancer evidence not just changed the landscape of head and neck cancer treatment in India, but also it got translated to, renal cell carcinoma, melanoma. We used to offer 40 mg. We used to say there is a trial in Tata Memorial Hospital. They added for head and neck cancer, but you can try this. But we saw a great evidence even in other cancer also. Thank you so much for that attempt and making accessible to a lot of patients. Dr. Cheta, in solid tumor oncology, genomic testing is increasingly becoming part of routine care, even at every center. And however, translating a test result into clear treatment pathways can be complex, we discussed before, especially when prior workup varies or access to newer therapies is evolving. In your clinical practice, how do you navigate these scenarios and what would help make precision oncology decision-making more consistently actionable, because access is an issue, already we discussed about it.
So how do I navigate? So, only genomic report is not enough. We have to add it with clinical information of the patient, how patient is clinically. So not only clinically, how is he financially? So all those things we have to take into consideration. So when somebody comes with the genomic report, the first thing I'll see is what is the kind of disease patient has, whether it is the disease which is very rapidly progressive. If some patient who has got a very rapidly progressing, and if we have some targeted therapy, it may not help. We may have to just start with the chemotherapy first, because by the time these drugs act, patient may not live, right? By the time they get the drug, patient may not live. So this is one thing which see clinically very important. Secondly, affordability, as we discussed, whether, so even with this genomic report, if we have something is actionable, is there, but whether we can give that is also very, so that is how we have to talk to the patient. Secondly, there are some things, tier 1, it may not be, like it is easy if it is tier 1 positive, EGFR ALK, we just write the treatment because we know that these are the things, these are the protocols and we have adequate evidence to give it. But sometimes there are some such kind of mutations which are actionable, but there is no guideline for that. So when we see something like that, then we discuss, like I discuss it in tumor board, that these are the patients, we jot it down and then we advise the patient, okay, you can take it. So this is how I do.
Right. So most of them we do see PIK3CA mutation for many cancers where there is evidence is still yet to be strong, but still we do offer in second line, third line when patient, performance status is poor or no other options, they're not willing for chemotherapy. Thank you so much. Jyoti ma'am, you're a trailblazer in sarcoma. When no one was like talking about NGS and sarcoma, you're the one who did it. In solid tumors, the integration of genomic insights into treatment pathways continues to evolve alongside expanding therapeutic options. From your experience, how are these insights currently shaping clinical decision-making in routine practice? And what factors most influence their effective translation into patient outcomes? When TMBs were not really discussed in sarcoma, you found out that high TMB we have to offer immunotherapy. Now the data is there. So how do you navigate such difficult situations or difficult clinical decision making?
So thank you very much indeed. A pleasure and privilege to be with many of my old collaborators, colleagues, friends, students, everybody, and all of you. And I must admit that I'm a hardcore precision proponent. And since I truly believe in this concept since really long, and I'm very happy that adaptability is increasing day by day, and ultimately, so when we say precision, it is not only sequencing a tumor. I would say it is sequencing of decisions. And many times, when patients are sitting with us, we know there are some signals in early phase, and till the time they reach to phase 3 and they come into guidelines, perhaps that patient may not be there with you. So that is the most critical time points, and perhaps you have to make most difficult decisions for that patient with all your inner conscious, and also the system support, which is many times fragmented, and many of my colleagues would agree with this, that this is the intersection where we have to really think hard, and we have to see that how things move faster in that direction, patient-centric manner, and especially in rare and complex diseases. I'm a passionate person who really do a lot of rare, ultra-rare, and complex cases, and there the evidence even is much more lacking. And to do those kind of randomized trials, to generate that kind of evidence, and to build guidelines, even more challenging and difficult. So I think understanding and interpreting data in different scenarios, different disease situations, and implementing that science so that it doesn't only reflect in publication but reach to population medicine, in my opinion, is most critical step, which large time it is lacking, and that's where the benefit doesn't really translate. Many times we are very happy, we celebrate the success that X thing is already there, it is in domain, and or even the reports we find, we are very glad when we see the mutation. But what about actionability? Then many times we are really challenged that there is no access. So I think ultimately, the insights, the knowledge, everything, till the time it is reaching the last person in the queue, our purpose is not solved. So we need to really work on, and a lot of us, my colleagues in Tata Memorial or India Institute, from our societies, from Immuno-Oncology Society, which very humbly I would say that we are making an effort that with this society which is founded by me and some of my colleagues, and we are trying to make that drugs like immunotherapy should be made accessible to everybody. We should bring more and more trials in the country and provide that stage and provide the chance to each of our patients. So I think till the time all these discoveries not reaching to our countrymen equally, till the time it is only a privilege rather than inequity, I would say, in a little blunt manner. And we all are from the leader, we call that from the topmost institutions, whether it is a, public or private, and I'm very humbled and privileged that I could work from both the sides. So I believe that it's our responsibility that, we should move in the direction so that we can make it accessible to everybody. India, I would say, should not be, only a recruitment site or only, something that we are implementing what is being discovered in the West. We know our own problems, we know our own solutions, we have discovered, we have worked in different directions, and we have proved that we can find our own solutions. So I think it's very high time a population of 1.5 billion should be the leader in the world in our own way. And cost constraints, when we can see as a constraint, it is also our innovation engine, and that's where this all abbreviated course of immunotherapy from Immuno-Oncology Society, or low-dose immunotherapy from Tata Memorial, or some repurposing of drugs which has come in, and it is showing a direction to large part of the world. Remember, developed world is only a fraction. Large part of the world is still low and middle income countries, and we are providing solutions to them. We can provide even bigger solutions. So precision is way forward. We have to work more intelligently and more adaptively.
Thank you so much, ma'am, for answering that question. Common tumors with rare mutations are rare tumors with common mutation. It's really difficult for us to handle. And also for people here, Jyoti ma'am did a significant work in publication of research, real-world evidence, especially from Tata Memorial Hospital, regarding sarcomas and rare tumors. She's the key person to found Immunological Society of India, and we had a privilege to hear from Nobel laureates as well. Thank you, ma'am, for such a groundbreaking work. And Anita, ma'am, you do work in medical college as well as corporate setup, and you do treat a spectrum of cases, poorest of the poor and richest of the rich. In solid tumors, genomic profiling is increasingly identifying multiple alterations, not all of which are clearly actionable, we just discussed. In your experience across adult and pediatric, how do you interpret and prioritize these findings in real-world practice, particularly when evidence is still evolving in some mutations?
Yeah, thank you very much, Kripa, for all of us bringing us together. Yes, we have moved into this era of modern oncology, where we all of us in the on the dais and out of the dais met over here to talk about 10% of the population who has access to revision care. Kripa, we are not discussing about the 90% of the Indian population who does not have access to any of these methods. I work in a private medical college, which is a university hospital back home in Chennai, where we treat patients who comes and gets treatment with Ayushman Bharat. They get treatment with the Kalingar card and Modi card, where there is no provision to do any molecular testing in that card, where is there no provision to do any immunotherapy in that card. Yes, you can do targeted drugs like rituximab, trastuzumab, bevacizumab, and that's what all my patients take, and I think that's 90% of India, and that's India. It's only the 10% of the population that we are now talking about where this precision oncology is creeping into it. So my thing, yes, we have done very well. When I go to my private practice, because it's a medical college which allows you, yes, we talk about only precision. Any tumor, we go for molecular testing and then we treat the patient. But once I'm in the medical college, we don't talk, we don't do any of these testing. What we do in lung cancer, we do an IHC, maybe an EGFR ALK, because I have only generic TKIs with me. I give it for CMLs. But I can't do an entire panel for lung for my patient in the medical college. So treatment is completely different within the definition of care, and that's 90%. Believe me, entire India is not accessible to what we are all discussing now. The one thing I want to say, this all, whether this immunotherapy, whether these molecular labs, and I think I met many of them outside, they are working into this. Please bring it cost effective. Please bring all these tests within the purview of at least any of the government scheme so that we can apply for all our patients. And all to the, like we also appreciate all the Indian companies which are coming with the generic. Now we have nivolumab generic, and we are doing many trials on the other immuno drugs for. Once they come, and that's the era when we are going to really enjoy. Yes, we have come down with the testing. Yes, we can do what is evidence-based, and I can give the drug. I can't sit in the medical college and say, you do 10 tests and meet me. Patient comes back. He said, I cannot afford NTRK inhibitors. I cannot afford lorlatinib. So should we do? Are we ethically correct to do this? Or it is also maybe unethical. They may come and say, why you did not do. So there's a huge area of unanswered question, not known things, deprived people, which we are not addressing, and that's how. And we are all here now discussing how to go forward to get access to be that 90% is what we are looking into. Coming back to Dr. Kripa's question, VUS. I think most of these oncology reports are little confusing. If you ask me, I don't have so much of knowledge. To read 3 pages, it takes so much of time. Am I giving the correct information? And they give so many choices, page after page. Yes, only at small place, they will highlight this is needed, that is the drug. Yes, we need to make our reports very, very user-friendly. Doctors like us who can read it, also to the patient who can read it. And her question was VUS. There are so many mutations and amplifications which gets reported in these reports. But then how does that affect you or affect me? It confuses the patient. He takes that reports, runs from place to place, checking his opinion, third opinion. They go to higher centers, but not needed. So our report has to be streamlined, only put in things which is applicable. Yes, if patient wants additional report, handed over to them. VUS, correctly, Dr. Kripa has said, might not make any sense. We may not have drugs, but you put it in the report. Patient is perplexed. I am also perplexed. I don't know what to do. So yes, now there is evidence. People are working on the tiers of the VUS, which is called variable of unknown significance, where nobody knows what to be. It has got picked up, comes reflected, but then how do we sort it out? Second is, firstly, we need to have these molecular tumor boards, get in touch with the experts. Also, we need to have there is something called there are guidelines of ESMO as well as in UK, it's called OncoKB, where you just report those targets where a drug is available to the society. You don't do all these things, and it's called the actionable target and clinically proven benefit. Like in lung cancer, you don't need to run that 500 genes panel. What will I do? I have only 10 drugs with me. So that's comprehensive. VUS, yes, comes into the report. We have to discuss. Secondly, an advantage of a tumor board is that you can link these patients having these rare mutations with clinical trials that's running all over the world. That's a very advantage. And where you also link it with AI, may not be applicable today, but might be used at a later date for interpretation of the report. So my thing to anybody, all this, you have to have a very comprehensive report. Just giving the drugs which I can write in the clinic, because one consultation takes so much of time. I do not know what to do with VUS, which Kripa has asked. Yes, it has to be discussed in the molecular tumor board. It has to go with the AI-driven opinion, maybe clinical trial, and some access to the patient. And as far as India is concerned, I told you, we are not discussing about the 90% of the population, but yes, whether this 10% of the population where we are discussing now can be extended into a bigger forum, and that's where Vikshit Bharat we are forwarding. Thank you, Kripa.
Thank you so much, ma'am. You put forward really right point regarding inaccessibility to the patients as well as the plight of clinicians with a report containing multiple VUS. For the healthcare leaders in diagnostics, I think the point to be taken, unless it is really actionable, please better not to mention, that create a lot of confusion. Thank you so much, ma'am. And now we had a lot of insights and discussion regarding genomic profiling and testing. Now let us discuss about how can we build a system which can deliver in a better manner. Dr. Suman, in a setting like India, where oncologists manage a wide diversity of tumor types, and patient needs. How can precision oncology approaches be adapted to become more practical, scalable, and impactful in everyday clinical practice? You do practice at Fortis, Gurugram, which is a tertiary cancer center.
Yes.
And what models or innovations do you see help bridge this gap?
Like you said, it's Fortis Gurgaon Tertiary Care Center. So like Dr. Anita ma'am said, it is actually catering the niche population who is paying out of pocket, or the insurance has a big, they have a huge insurance to cover the therapies. So we're not actually catering to that 90% of the population where we actually need all of this. But I'll tell you, even in a tertiary care center, it is not like everything is going on the way it should be. And the way to bridge the gap is multiple panels are there available. And for example, me as a medical oncologist probably understands certain A, B, C, D kind of panels. Now the person goes to the radiation oncologist and sends X, Y, Z. And then the gynecological oncology surgeon is sending something else. But none of them can read the report. Right, so they come to me and I know that lab has not done the actual, they haven't studied the whole gene. And so I know that certain things have been missed. So I know that this is not the right interpretation of it, but I don't know what to say because the patient has come to me and I cannot say, no, that doctor has sent the wrong, it has not actually set the right platform. So these are real practical problems in a tertiary care center. So there has to be, and this is the actual need of the hour everywhere. You have to have institutional practices where, for example, like ma'am said, you don't need a 500 gene panel for lung cancer. No, you just need certain number of genes. So you curate a panel for your institution. Now I know in Fortis Gurgaon people can afford. So I curate the one that is practically sensible for my population. But I should have another panel for those population that are upper middle class who come to us or middle class who come to us, so I could use that panel as well. So there has to be a step 1 and a step 2, or there should be some reflex testing of that sorts. Secondly, I think insurances need to be adapted for oral medications also. There are so many oral targeted therapies and we are always fighting with insurance companies to give access. People, out of pocket is not sustainable. Even if they have money, how long will you do it? What, 40 lakhs, 60 lakhs, how much can you shell out in a year? So insurance companies really need to work on this. The platforms of testing need to be made cheaper. They need to be made cheaper. There has to be some platform in India across that say, these are good labs, these are cheaper, and then you can cater to those 90% of population. Otherwise, you're just always, and all this discussion is for that 10%, and believe me, even 10% can't afford. It is not a sustainable model. Thirdly, I think education of the person, education of the person writing the report, I think it's a moral responsibility. It cannot be that in my experience, there has to actually be evidence when you're talking. There has to be real world evidence. Here we have women who have generated data, so you have to speak with your data. We have to have our real world Indian data because we cannot always extrapolate the Westerners' data. Also, I think it's time India becomes the lead to actually have our own data, our own genomics, our own precision oncology, our own guidelines. I think it's high time we do that as well. Thank you.
Thank you so much. So we have to curate the platform for each and everyone. So like NGS, snapshot, PCR, just like how we evolved from PCR to NGS. So rightly you mentioned. And the real problem is most of the roles are not covered with insurance. So there should be collective system effort should be there. Vanita ma'am, in solid tumor oncology, translating research insights into everyday clinical practice is an ongoing priority. In the Indian setting, where do you see the greatest opportunity to strengthen this translation? And what approaches could help ensure that evidence more consistently benefit patient care? Because you are working in a center where the research can be translated to the clinical practice, and how can that be amalgamated in the private setting also?
Yeah, thanks. So I agree with the comments of all the panelists, and as I think as Jyoti had said that if you have the evidence but you're not translating it and you're not able to make a difference to all, perhaps saying to every single patient that you see, maybe that may be utopian, but at least the majority of the patients whom you see, if you're not able to translate that evidence, then matlab iski value kya hai? So absolutely, we need to strengthen our system to ensure that we are able to translate the majority of the great advances that are happening. So how do we do that? I think most important is to contextualize the evidence. So we have global evidence. We need to contextualize that to, is this relevant to our patients, right? So perhaps we need to have resource stratified guidelines to say that, in these certain, this population of patients, this is what is the appropriate methodology, this is appropriate therapy to do. In terms of precision oncology, there are multiple steps that we can strengthen our system. So from testing, so we need to have the test available. So if you don't have the test, you don't have the result. So then you don't have the result, then you don't have the option of offering your patient precision medicine, right? So from testing, we need to strengthen our pathology, we need to strengthen our education so that we are able to get those tests to our patients. Secondly, once you have the test, we need to be able to interpret that result, to have an ability to understand what that report says. So that, again, is a whole different set of learning, which perhaps a lot of us did not have in our training. So we need to strengthen that understanding. And then, I guess, most important is access to drugs. So having a report and not being able to action upon that report, that's of no value, right? So we need to be able to get not just the original molecule, perhaps generics, perhaps biosimilars, so access to drugs. So I think multiple steps of being able to impact and get all of these great new research advances to our patients, and so many ways that we can do this.
Thank you, ma'am, for the powerful insight. Dr. Cheta, emerging therapies, including cellular and immune-based approaches, are beginning to expand into solid tumors. Following their success in hematological malignancies, we saw CML, how it's a poster boy. So, drawing from your experience across both areas of hematology as well as solid, what clinical, institutional, and patient-related factors will be a key to enabling their thoughtful and effective integration into solid tumor cancer care?
So solid tumors are different from the hematological malignancies. So I think they are less vascular, sometimes they are bigger tumors. So cellular therapies are not very easy in solid tumors, and we don't have enough data. Here I would like to request Dr. Vanita to take up the protocol and start a new trial on solid tumors and cellular therapies. So once we have a data, institutes like us, we will be able to use it. Second, you asked institutional. Right. So we should have more ACE institutes like Tata Hospital in different cities in India. I think they have already started doing that. So because, if a person is staying in Nagpur, for him it is very difficult to come to Tata Hospital for the therapies like this. They are not easy. Patient has to stay here for 1 month, which is not easy for the patient. So we should have more such institutes. And this institute, they require leukapheresis, they require a proper person to do it, they require cold chain facilities. So we do need good tertiary care institutes all over the India in different places. That is what institutional is required. And what was the third thing you asked was patient-related. Yeah, so affordability is very, very important. And these drugs, these therapies are very expensive. So if we engineer them in India, I think they have already started doing that, then price will go down. And patient-related, I think we will get more patients who will go ahead and take these therapies. And they should be also done early in the lines of therapy. If we are doing it as a last line of therapy, then most of the times patient may not respond. So that is also very important to do it early in the therapy.
Points well taken, ma'am. Jyoti ma'am, as precision oncology advances, what systemic changes, whether in multidisciplinary collaboration, Dr. Suman Karanth already mentioned about the difficulties. I hope there are not much radiation oncologists and surgical oncologists are here. So multidisciplinary collaboration, treatment access are clinical pathways. Do you think these are most critical to ensure these approaches can be applied more consistently across diverse care settings?
So thank you, Kripa. So I would say, absolutely. There is no doubt about it. We need collaboration. We need collaboration at multiple levels. We need institute level collaboration while you say different disciplines, and everybody needs to understand the science behind, and also respect boundaries. I completely agree with what was said. And then, cohesively, if we work patient-centric approaches, not in an utopic world, but at least in reality and at least real senses, that what matters a lot. Because I completely echo that, perhaps if I give some surgical information to a patient, I may only deliver some theoretical things what they are. While, and the similar thing when if somebody is giving a medical or precision oncology related information while they are into different disciplines, perhaps they will not be able to do that kind of justice. So I think that kind of setting up boundaries and then collaborating would perhaps increase the transparency and also help in building up the systems. Also the belief system, many times still I feel that there's a lot of resistance in other disciplines. Whatever science is moving, the systems are lacking. So unless and until we really sit together, discuss it out, what are the doubts, myths, most importantly, till the time you will be able to convince the community, first you need to convince the doctors among themselves, among the oncologists among themselves. So that kind of dialogue is very, very important. Our open dialogue, understanding there might be some biases in somebody's mind, but that can come up when you discuss and you can get over with those things. Then national level collaboration, international level collaboration. I think this collaboration is the key, and public-private partnership, in my opinion, is the need of the hour. We cannot work in silos. There is so much good institutions in public, there is so much good institution in private, and there are strengths and weaknesses of both. We need to come together so that we can really bridge that gap. Third thing, academia industry. Again, collaboration. I think we should not be shunning away that this is industry, we are academics. It's not like that. I think to give the best possible care to our patient, to give the best possible chances, I think all sorts of collaboration and multi-levels should come into picture in all possible ways. And again, as I said before, also till the time some innovation, discovery, howsoever good it is on the paper or it is on the it is available for a fraction of people, it's not really making a difference. Till the time, if we can reach to masses, these all collaborations are very, very valuable. So that's what is my approach, and I think we are really privileged that we are in the city of Mumbai. Perhaps a lot can be done. Perhaps a lot can be done with the older colleagues, collaborators in multiple ways, and we can find a way with this approach.
Points well taken. Each patient is different, and each patient decision should be collectively taken by all specialties together. So the tumor board is most encouraged not just in one-tier city, but also two-tier and three-tier city oncology centers also. It's way to go forward with the multidisciplinary team action, not just within, but rightly mentioned with academic collaboration, industry collaboration. All of us have to collectively work together to deliver best to the patient care. Thank you, ma'am. Dr. Anita, as precision oncology continues to evolve, what practical steps, whether in testing pathways, treatment access, or clinical workflows could help make these advances most consistently applicable across diverse patient population and care settings? I think you are the right person to answer because you deliver to different settings.
Yes, thank you. I think we are at the right time. The She Bill is coming in the parliament, and we want that 1/3 for this. And rightly placed, a Voice of Health has brought all the women in oncology out here to make some change, and I'm for it. Okay, and I'm sure you're also for with me. Yes. Just a big hand for women. I want that 1/3 seat. Maybe I'll stand for election next time. Yeah, 2/3. Okay, 1/3, 2/3, everything. So yes, that's how we are all here to bring real changes. And some of the things that really I feel that needs to be done is, I'll tell you some 10 points. One of them is that, why don't we have centers, and not why we, it's already started, one aims in all state. Okay, that's what all of them highlighted, and not AIMS or any other higher tertiary institution. As much as I know, with the present government, each and every 22 states in India has one AIMS. There is 22 AIMS. So that gives you a quality care. So why, and this being a difficult disease, it's a killing disease where we have done well. So to be treated in higher centers where all sorts of facilities to be available. This is my first point, and we can refer, whereas Spoke and Hub model, like many of them has said, done. Next, why do we need to send the samples to 3 lakh rupees, 2.5 lakhs rupees? Can't we have those type of centers done in India? We also want to do our test for the patient. Same drug, same gene, same method, but made in India. So again, I request all the MNCs company to have your outlets out here and build it, because you may charge 3 lakhs for one patient, but if you come down with the cost, I can give you 1,000 cases. So it almost your profit will be the same. So affordable precision oncology lab to be present at India, and definitely there has to be accreditation because we are going to use bigger drugs. So testing becomes equal. Next, regarding the guidelines, if you see ESMO has a clinical benefit ratio where also they have a section which tells that this is for the low income countries. We should have in our ICMR guidelines, this is the minimum test we should do. So no patient is derived. If you can't do in my hospital, okay, I send to my, in Tamil Nadu, the nearest AIMS is AIMS Madurai. I can send them, yes, you do it and you come back to me. So that type of model where a basic testing which has to be approved by the local insurance and patient gets it done, does and comes back. Only limited genes panel for accessibility, that was Kripa's question, how do we? So these genes I do because I have a drug. I should have drugs which are generic. I think most of them are coming into generic. Immunotherapy we were not able to afford, but now, yes, we have immunotherapy drugs, which is just 40 milligram is 10,000. And that's a big thing that has happened. And we do PDL1, but we can't give the drug to the PDL. Now, with this accessibility, more companies, I want more Indian pharmaceutical companies, more R&Ds, and I think government is giving grants to develop INDs in India. So please use that, bring all these generic so that it is affordable. And HER2, I have patients, but I can't write. So what is the new? I have done the test. I don't know what to do. So yes, those type of higher molecules, and I'm sure over a period of time, it will take another 3 to 5 years for us to get into, yes, everybody has access to them. Point number 5, to incorporate AI and precision oncology at MBBS level. They should learn the signal transduction pathway, and then it should be there. Oncologist needs to be trained from their first year in molecular oncology. We learned it after we finished our graduation. So that, and this becomes a part of the treatment. It should come in the ICMR guidelines for limited resource countries, and lot of NGOs, donation, what we heard from everybody, collaboration, public-private partnership, even the machines for PET CT needs to be come up. And that's how we will go to Atmanirbhar Bharat. Thank you very much.
Thank you, Dr. Vanita. What if the genomic testing were universally available and free tomorrow? Would outcomes actually change, or is access to testing not the real bottleneck?
Yeah, if it is accessible, but the drug has to be accessible. Right. Yeah, I need both. Otherwise, I will not write. I need both. Tomorrow morning I have NTRK positive, and patient, what will I write if he can't buy that? So why did you do the test? Okay. So yes, you're right. Both should go parallelly. Industry, lab, technology, R&D, you, me, public and government, first of all.
Dr. Jyoti Bajpai, what needs to move first? Better Indian data, better drug access, or better clinical infrastructure? What needs to move first out of 3?
I think infrastructure, because if infrastructure is not there, we cannot do anything. So first, you are asking the ladder, so first should be infrastructure availability, and then it will give path to everything else.
Vanita ma'am, you're in the premier institute, oncology institute in India. What needs to move first in your thought process?
I agree. I think of course, all need to move. Definitely, we need test, we need drug, we need infrastructure. But infrastructure, if it's not there, then none of the other things matter. So infrastructure, if we have to prioritize infrastructure, but I think we need to prioritize all 3.
Dr. Chetna, precision oncology in solid tumors, are we solving the right problem for the right patients or optimizing care for privileged few?
So just now it is for privileged few, but we always start like this, right? Even for immunotherapy, we started like that. I'm sure in the next 2 years, it will be for everyone.
Right. One thing in Dr. Suman, one thing in oncology community needs to stop doing. It's a very controversial question though, and one thing it urgently needs to start to accelerate real-world outcomes in solid tumor oncology.
I think please don't send NGS if you don't have a plan for the patient. Just don't send it just because everybody is sending it and I should also get on the bandwagon. Please understand, have a plan. If the results come, you should have some sort of algorithm that you would do. And I think people have to educate themselves. This is the actual need of the hour. Yes.
Rightly said.
think I would like to add, we also need to have a good data keeping. That is what we oncologists lack. I mean, not in TMH, but I'm in a private practice. I have got so many patients, but I do not have data. Neither I have collaboration with anyone. So I think we should start doing that in a private practice. There are so many patients, so that we can come out with a very good Indian data. Why only they work hard? No, everybody should be working hard on data keeping.
Correct. All private practitioners also should come forward to add more data. So the outcomes like we can publish in real world data will be very strong.
I think many of the companies have started doing, when you give a free sample PAP program, that gets recorded. So many of the companies who are giving the PAP program are already collecting data. What you said correct, Dr. Chetna, and if you translate that gets into publication, we have huge, okay, yeah. Like how they did for CML. The first drug that we use, imatinib, Gleevec, how the data, when the access program data was utilized for publication, you get it signed. So I tell everybody, if you're giving a PAP, if you're giving a free vial to the patient, utilize the data.
I think Voice of Healthcare did an amazing job in curating the panel with the 5 powerful women here. So thank you so much for this opportunity one more time. And I think we overshot the time. And once again, thanks for the opportunity to interact with all of you, the eminent people in the field of oncology, the women we always look up to. Thank you so much.
Thank you, ma'am. Thank you so much. And you rightly stated that this was a powerful session and yet insightful. That truly reflected on how precision oncology is shaping future of cancer care. Now, I would like to invite Dr. Kripa Bajaj to please come on stage and felicitate the fellow panelist.
I wish you conduct the session later in the women's day next time, like with this kind of women on panel.
Point well taken, ma'am. Can we have the certificates? I would like to start with Dr. Suman S. Karanth. Let's have a round of applause, guys. Dr. Vanita Noronha. Dr. Jyoti Bajpai. Dr. Anita Ramesh. Dr. Chetna Bakshi. Now, I would like to call Dr. Manisha Khurana to please come on stage and felicitate Dr. Kripa Bajaj for exceptionally moderating this powerful discussion led by all women. I request everyone to please come on center and then we'll have a group picture here. Thank you, ma'am. Thank you so much. Thank you, everyone.